seeing that by 2016 we have much more cases. We have when we have more incident, therefore in the future we will see even higher prevalence. So there is no surprise we are seeing more and more Crohn's disease patients. It is not only about prevalence and incident, it is also about severity. This is a study from 8 countries in Asia. The mean follow-up duration is 1.5 years. The probability changing from inflammatory to stricturing or penetrating disease in Asia, only 10% of patients could receive biologics. So this is very much challenging in Asia because of the lack of the use of biologics. In Vietnam, we have a study of 37 patients, a small study in my center. We could recognize that the percentage of stricturing is almost 50% and penetrating like a third of our patients have fistula, have penetrating lesion. So on your left-hand side, patient have cachexia, or in this patient, multiple surgeries, 6 operations until patient receive Crohn's disease diagnosis. This is a fistula. This is actually in a video, every time we try to touch the lesion, then the pus will come out. The median time from symptom onset to diagnosis is around 7 months, from 4 to 12 months. So around a quarter of patients receive definitive diagnosis. After 1 year, a quarter of patients, they have to suffer for 1 year before we have final diagnosis. The problem is this is very challenging to diagnose because there are so many differential diagnoses. And the most troublesome differential diagnosis is to differentiate between intestinal TB, intestinal tuberculosis versus Crohn's disease. And honestly, we don't have adequate number of specialists like GI pathologists performing pathologies with a standardized protocol. We still don't have that. We also have the lack of biopsy protocols or endoscopies, and we have the lack of basic tools such as fecal calprotectin, MSc.BS. Not every center has those tools available, and the misunderstanding is that people think pathologists they could define Crohn's disease, but actually it is very challenging for pathologists because not every time they could say for sure this is Crohn's disease. So there is no gold standard to diagnose Crohn's disease. It will need the diagnosis will require clinical evaluation, imaging, histology, endoscopy, and lab testing. In Vietnamese context, I think follow-up is also important because sometimes the first visit didn't provide adequate information to make diagnosis. Sometimes we even have to try some treatment in order to confirm the diagnosis. It is helpful to differentiate Crohn's disease versus other diseases, in particular tuberculosis. I would like to share a case to illustrate what I just said. This is a male, 29 years old. 1 month before, patient have right lower quadrant pain, diarrhea, weight loss for 8 kilograms, very high fecal calprotectin X negative. So people suspected Crohn disease. This is the ascending colon and the cecum area. CTE show one thickening in ileum and cecum. We have ileo and cecal fistula and abscesses. So when we read CTE, we suspect Crohn disease rather than ITB. But for pathologists, they found caseous necrotic granuloma. So actually, we suspect this is intestinal TB rather than Crohn disease, and we try anti-TB drugs. Patient responded very, very well. After 6 months of treatment, we could see almost complete healing. So this is quite complex. If pathologists, they are not careful, if they didn't find the caseated granulomas, then we would have treated this as Crohn disease. So for such difficult cases, we have our MDT meeting. In Friday afternoon, we have imaging doctors, we have GI doctors, we have pathologists. Usually, clinical practitioners will suspect Crohn disease and we're gonna ask pathologists. We perform CTE and we tell endoscopists, try to cover the ileum and try to get adequate number of samples and send those samples to pathologists. For difficult case, we're gonna have MDT meetings to come up with the orientation to manage patient. In the next part, I will share more about diagnosis. So diagnosis is challenging. Treatment is even more challenging. We have to face the problem that patient may not respond, patient may develop infection. The first challenge in treatment is which strategy should we choose, and when we choose biologics, which biologics should we choose? And every day we have to meet 70 to 100 patients every day, every morning. And right now we don't have local or even regional guidelines to manage our patient. So the first challenge in treatment is which strategies, step up or top down. If we choose step up, then of course it has lower cost, but it is quite reactive. We wait until patient has damage, have clear symptoms, clear signs, then we use the drugs. So, and maybe with this approach, the biologic efficacy would be lower. Another strategy is top down. We have higher costs, even though it is proactive, and maybe social insurance they won't reimburse. And we have risk of infection when patients use a lot of immunosuppressant. So for step up, we have the risk of under treatment. For top-down strategies, we have the risk of over-treatment. So how could we have a balanced approach? Luckily, in Asia, we have a pretty good balance approach, accelerated step up. And this is our approach in my hospital. We look at the risk factors like young patient, extensive anatomic involvement, deep ulcer, perianal or severe rectal disease, prior surgery, stricturing, penetrating lesion. So for those patients, we're gonna have accelerated step up or top down. If they don't have those risk factors, then we're gonna use conventional step up. So in reality, when we apply this strategy, we are now more proactive. We try to treat more aggressively to reduce the risk of long-term complications. And if patients already have complications such as stricture, such as fistula, then proactive treatment will help to prevent secondary complications, prevent further need for surgery. In this study, we have 56 patients in our hospital. The use of accelerated step up or top down, a quarter patient will use this approach. Crohn disease, we have 24% and UC 33%. For use, the majority of patients receive anti-TNF because it is the only available drugs for us, or tofacitinib. Just recently, we got one patient with that drug. So we are waiting for interleukin 12, interleukin 23 inhibitors. In the past, we only have TNF alpha inhibitors. So for primary non-responder or secondary non-responder, we don't have other option. Another challenge is the risk of infection. And the third factor is extremely important, the financial factor. When patients, they couldn't afford the drugs, then we have to de-escalate. Sometimes we de-escalate prematurely, too early. So we see patients did respond, but they run out of money. And because of the lack of social insurance, the lack of reimbursement, so we couldn't continue to treat. And we don't always have TDM, therapeutic drug monitoring, and sometimes we also have the problem of improper escalation. I would like to share about infection management in my hospital. First and foremost, we always check for HPV, HIV, HCV, and latent TB before we prescribe anti-TNF. And we will provide prophylactic treatment as needed. We're gonna check IGRA after 6 to 12 months. If IGRA is positive, then we may need we may need prophylaxis treatment. We know patients are vulnerable to infection, so we should vaccinate with whatever available vaccines we have. And we have hotline when patients have suspected signs such as fever. They should call immediately. Those infections could be serious infection, opportunistic infection. And in Vietnam, BCB, E. histolytica, strogeloid steroid release, or every time patient have flare, we have to remember about infection. We have to check for infection every time they got hospitalized because of flare up, and try to control the disease with other drugs and avoid restrain from using steroid, because we're gonna have higher risk of infection if we abuse steroid. Even though we are careful like this, but it doesn't guarantee zero infection. Some patients suffer a lot from severe infection. This is a patient 9 months before hospitalization. 9 months before hospitalization, patient have the diagnosis of Crohn's disease and receive steroid and azathioprine. Patient didn't respond. At 5 months later, patient escalate. We escalated infliximab plus azathioprine. After the induction period, patient developed fever and anemia. Patient was diagnosed with Clostridium difficile infection. We used vancomycin. There was no TB, no abscesses, no CMV, but patient continued to have fever. So we stopped infliximab and azathioprine. Patient refused bone marrow aspiration. After we stopped the treatment, patient no longer have fever. Hemoglobin restored to normal level, and patient want to restart treatment. So we restart infliximab. However, patient continue to have fever, hospitalized, and diagnosis was EBV positive. Later on, patient passed away. Previously, EBV testing was negative, so we have to have high suspicion of infection. And the reality in Vietnam is that we try to avoid surgery. We know over the time, without proper management, patient may develop complications such as stricture, fistulas, or abscesses. Some complications require surgery, medical treatment. It's not enough for them. And we know that if we intervene earlier in the window of opportunity, then patient could respond very well. But we have to remember, after surgery, after we remove those lesions, then actually that is also a window of opportunity to use medical treatment. Some patients with very severe stricture, very severe fistula, medical treatment wasn't effective. They were transferred to us. We performed surgery and then they responded very, very well to medical treatment. So sometimes we have to accept the fact that patients have to receive surgery for their current existing lesion. We have to check for clinical symptoms after we initiate treatment. After 2 to 4 weeks, we're going to perform CRP testing, calprotectin. After 3 to 6 months, we re-perform colonoscopy. 6 months or 9 months after we initiate the treatment. And the same for CTE or MRE. Hopefully, within this year, we're going to have a new method to evaluate intestinal ultrasound. So the follow-up could be done earlier with ultrasound. It is quite stressful because there are many tools to monitor our patient. So actually, in my center, we have this kind of table like this. This is a piece of paper showing the result of the testing for this patient. So there are some few key points I want to share with you. Crohn's disease is increasing in Vietnam, and we don't have the gold standard for Crohn's disease, and the diagnosis depend on multiple factors, multiple modalities. Differential diagnosis is still a major challenge, and we have to overcome this to manage our patient.
Cũng nghĩ rằng đó là một chiến lược phù hợp ở tại khu vực châu Á. Khi bệnh nhân đang dùng anti-TNF thì chúng ta phải rất cảnh giác với cái việc nhiễm trùng, và cuối cùng là chúng ta cố gắng đừng tránh phẫu thuật đối với những bệnh nhân
have high suspicion of infection and try to perform surgery as needed when patients already have certain complications. The follow-up protocol would be very, very helpful. for doctors who are very busy. And now we are still waiting for more biologics and guidelines in the ASA. Thank you so much for your listening. Many thanks for the presentation by Dr. Đặng Minh Luan. In the conclusion, Dr. Đặng Minh Luan share about our eagerness to wait for more biologics and guidelines. I'm sure the next presentation will share with us more about available biologics and about guidelines. During discussions, we're going to discuss about the future. We may ask for experience from South Korea about the development of guidelines. We know that next year, 2023, we're going to have Dr. Đặng Minh Luan and Associate Professor Bùi Hữu Hoàng. They're going to prepare a consensus for Crohn disease management in Vietnam. And to continue, I would like to invite Professor Byong Duk Ye. Like I already shared, this is a very prestigious professor from Asan Medical Center, Seoul, Korea. He is member of many prestigious associations, especially CASIC. The number of publications is more than 300. And now I would like to invite Professor Byong Duk Ye to share about early diagnosis of Crohn disease from theory to practice in Asia.
Thank you for the very, very kind introduction. And it's my great honor and pleasure to have an opportunity to at this prestigious meeting. And actually, this is my third time to Vietnam and second time to Hanoi. And I'm always feel very comfortable when I visit Vietnam. And today I would like to talk about the diagnosis of the Crohn's disease, especially focused on the early diagnosis in ASEAN patients. This is my disclosures. So everyone knows about the ulcerative and the colitis and Crohn's disease, two representative forms of inflammatory bowel disease. And Crohn's disease can involve the whole GI tract, and although the ulcerative colitis can involve the superficial layers of the colon, Crohn's disease has characteristics of transmural inflammation with skipped inflammatory patterns, and patients usually present with abdominal pain, weight loss, and diarrhea, and perianal problems. And as covered by the previous speaker, both Crohn's disease and ulcerative colitis develops in the very, very young age, and it is lifelong chronic disease without definite cure. And because the Crohn's disease has a relatively low mortality, the number of patients is gradually increasing, and we need to focus on the lifelong management of the patient with Crohn's disease. And it is not limited to bowel only. It has multiple extraintestinal problems, including joint problems, skin problem, eye inflammation, etc. And if patient has a long-standing uncontrollable inflammation, patient can have the kind of the malignancy such as endorectal cancers. Yes, UC is increasing worldwide. In Western countries, the incidence of the IBD is relatively stabilized. But as you know, the incidence of the UC is increasing in Asian countries, and this is the situation of Korea. Then same for the Crohn's disease. Although we have still lower incidences of the IBD in Asian countries, it is steadily and gradually increasing. I think it will be the same phenomenon in the Vietnam and Southeast Asia. And this map shows the worldwide incidence of ulcerative colitis. Unfortunately, I found that there is no clear statistics for the incidence of ulcerative colitis in Vietnam, and the same for the Crohn's disease. I think that you will have the more clear statistics of the IBD incidence in Southeast Asia, including Vietnam. As shown by the previous speaker, and the IBD is increasing in Korea and the other countries in Asia, and the upper part of this slide showing the increasing incidence of the Crohn's disease and ulcerative colitis in Korea. And actually, year 2020, in our country, we have around 25,000 Crohn's disease patients nationally. And the same trend is also shown in Taiwan. 2 years ago, we published an IBD fact sheet in Korea, and I will show this statistics briefly. And this is a nationwide data combining the ICD code and the V code. V code means the code given to the patient with inflammatory bowel disease, because inflammatory bowel disease is rare and intractable disease. And for the 10 years, as you can see in this graph, the number of patients with Crohn's disease and ulcerative colitis increased by over 2 folds. For Crohn's disease, it increased by about 2.4 folds over 10 years. But this is the cases of the new IBD patient diagnosed year by year. And in 2019, about 1,800 Crohn's disease patients was newly diagnosed in Korea. How about age of diagnosis? I think that will be the same in Vietnam. And the peak age of diagnosis of Crohn's disease is 20s in both male and female. And you can see this pattern of the high incidence of the Crohn's disease in young age group. Crohn's disease etiopathogenesis is not so clear, and we know that there is a clear genetic predisposition for patient, and there is some abnormal immune response between host and gut microbiome, and environmental factors like smoking and pollution and stress can contribute to the development of inflammatory bowel disease. And we know that there is a preclinical stage of inflammatory bowel disease. And even in the preclinical stage, inflammation starts, and there is an abnormal immunological interaction between host and the gut microbiome. And if patients have some symptoms, we can diagnose as Crohn's disease. And after Crohn's disease, if we do not treat patient properly, accumulation of the bowel damage is progressed, and it is very, very difficult to treat patient without complication, even in the advanced stage. Next one is diagnosis. So why is early diagnosis of Crohn's disease so important? This is gross picture of the Crohn's disease and ulcerative colitis. As I mentioned before, ulcerative colitis is relatively superficial disease, but Crohn's disease is a transmural disease. And at the birth stage, there is only inflammation, but if bowel damage accumulates, patient will have the various complications like fibrotic stricture and penetrating complication leading to abscess, interbowel fistula, enterovesical fistula, etc. So before development of that kind of the complication, we have to control disease. This is a very famous cartoon showing that 3 pillars of IBD care in modern era. The first one is early intervention. Next one is T2T approach. And the third one is tightened monitoring. And by combining these 3 strategies, we can change the disease of IBD, especially Crohn's disease. And because Crohn's disease is lifelong illness, it is very important to communicate with patient continuously. To do an early intervention, I think that early diagnosis is very, very important. Before we apply early therapeutic intervention, early diagnosis of Crohn's disease before progression of digestive damage is very, very critical. This is the new concept, old concept and new concept of the IBD management. And we know that IBD is a progressive disease, especially Crohn's disease, a progressive disease. And previously, we treated the patient all the same way, but in this area, individualized therapy is important. Previously, we focused on the clinical symptoms only, but now we are treating not symptoms, and beyond the symptoms, we are treating inflammation. So we have to utilize more objective targets and objective tool for monitoring of patient. And as I mentioned by Dr. Luan, accelerated step of top-down strategy is needed for patients with poor prognosis. And we also need to apply tight monitoring. So Crohn's disease is a progressive disease, and this is a very, very famous cartoon showing the progressive nature of Crohn's disease. As you know, the patient symptom can show waxing and waning, and patients have no symptoms at some stage, but even that stage, bowel damage is progressively accumulates, and finally patient requires surgery because of the stricture or penetration. And there is a definite window of opportunity here in the early stage of diagnosis, and because all of the drugs we are using for Crohn's disease is anti-inflammatory agent. That means that all drugs are controlling inflammation, but if fibrosis or penetration develops, that drugs do not work. So we need to control inflammation before development of this kind of the complications. If we treat patient properly, we can show this type of graph, patient course, without progression of bowel damage. This is very famous graph showing the natural course of Crohn's disease in France, showing including more than 2,000 patients in France. And as you can see in this graph, over 20 years, patients with inflammatory behavior decrease gradually, and patients with penetrating or stricturing behavior increase gradually, especially penetrating complications. So because of this kind of complication, so many patients require intestinal resectional surgery. So if we treat patients in the early stage, we have high potential of modifying disease course. And if we patient in the late stage of disease, anti-inflammatory drugs do not work for in this stage of patient. That's the problem. However, unfortunately, even in Korea, we are diagnosing patients with advanced disease stage. And when we analyze data of the population-based IBD cohort study from Songpa Gangdong district of the Seoul, about 20% of patients had already complicated behavior at the time of diagnosis. So we have to reduce this proportion of patients with complication at the time of diagnosis. So I would like to cover the diagnostic delay in Crohn's disease in several studies. And in the Swiss IBD cohort study, they analyzed the interval from symptom to IBD diagnosis. And as you can see in this slide, the interval was 9 months for Crohn's disease and 4 months for ulcerative colitis, and it was statistically significantly different. And it was the same for the Romanian National Registry. And Crohn's patient had more diagnostic delay compared with patients with ulcerative colitis. So what are the risk factors for diagnostic delay in Crohn's disease? And there has been a Swiss IBD cohort study, Romanian study, Indian cohort study, and small-scale Korean single-center studies. And diagnostic delay was defined as the interval from symptom to diagnosis as 18 months or 24 months or 21 months. And these are the risk factors for the diagnostic delay. And common risk factors were ileal disease. And in India, anti-TB treatment was risk factors of diagnostic delay. And in Korean studies, perianalitis compared as initial chief complaint was also risk factor of diagnostic delay. What are the outcomes of diagnostic delay? Yeah, this is the outcomes of diagnostic delay, and we can expect these are poor outcomes. And if patients have diagnostic delay, more patient requires intestinal surgery and more patient showing a valve stenosis. So we need to make an early diagnosis of Crohn's disease. Next one is Crohn's disease diagnosis. You know, this is very difficult to make a proper diagnosis because there is no single diagnostic gold standard criteria for diagnosis of Crohn's disease. First, we have to be focused on the patient feature, diagnostic features, because in most studies from West and from East, Crohn's disease develops in young age. There is a small peak in old age, but this phenomenon is not universal in Asian studies. So if we summarize the peak age of the diagnosis among Korean, Japan, and Chinese and Thailand studies, as you can see, the peak age of Crohn's disease diagnosis is 20s or teens or 30s, mostly 20s. So if patients have Crohn's-like symptom in very old age, there is a lower probability of Crohn's disease diagnosis in that population. Symptom, you know, the abdominal pain and weight loss and diarrhea are three major symptoms, but the symptoms start very, very insidiously, and patients have chronic symptoms usually over 6 weeks, and symptoms shows wax and waning patterns. So if we see the patient suspected of Crohn's disease, we have to make a detailed history on that patient, including symptom onset and characteristics of symptom like nighttime abdominal pain and recent weight loss. And some patient is confused with irritable bowel syndrome, even in Korea and even in other Western countries. And we have to focus on nighttime pain and weight loss and abnormalities, because these features is not common in irritable bowel syndrome. Differential diagnosis is very, very difficult in some cases, and we have to focus on patient presentation like orogenital ulcers, extraintestinal TB, history of medication including antibiotics, NSAID, and patient demographics suggesting the ischemia, and previous treatment like radiation or diversion. What are the signs of Crohn's disease? Usually, because Crohn's disease involves like low area of the bowel, patient have pains in like low quadrant, and if complications develop, we can palpate mass in like low quadrant. Another thing is perianal examination. I think that it is very important to take a history of perianal problem and make a physical examination on the perianal problems for patients with Crohn's disease, because some patients develop perianal disease before presenting GI symptoms, and about 10 to 15% of patients develop perianal problem first before presenting with GI symptoms. As Dr. Luan presented in his data, I heard that about 27% of the Vietnamese patients had perianal problems. And this is summary of data on the perianal disease at the diagnosis of Crohn's disease. It is quite high compared with Western data. And in Korean data, we had over 40% of patients have perianal disease at the time of diagnosis, which is quite high compared with Western data. Recent meta-analysis also suggested that there is a difference in the prevalence of perianal Crohn's disease according to the ethnicity. As you can see in the graph, Asian patients have higher prevalence of perianal Crohn's disease compared with the Western patient. This also shows the high proportion of patients with the perianal Crohn's disease. And in Korean nationwide population-based study, about 40% of patients had a perianal Crohn's disease, which was quite high compared with Western data. Laboratory finding is very non-specific, but almost over 90% of patients have any abnormalities in CBC, chemistry, ESR, or CRP. And for differential diagnosis with IBS, we can utilize fecal calprotectin, but I was informed that fecal calprotectin is not so easily available in Vietnam. ENCA is not essential for diagnosis of Crohn's disease, but it will be helpful for differential diagnosis in some cases and for prognostications. Endoscopy is essential, and I think that all of you are the specialists in endoscopy, and colonoscopy is key for the diagnosis of Crohn's disease. And when we analyze the findings of the colonoscopy, we have to consider multiple factors, including location and distribution of lesions, continuity of lesion, direction of ulcers, and mucosa around ulcers, and other features. Because disease have the preferential area of inflammation, for example, intestinal TB and Crohn's disease and GI Behçet disease, Yersinia enterocolitis commonly involves ileocecal areas, and other diseases have their own preferential areas of involvement. You know, the various colonoscopy features of Crohn's disease, including very early lesions and very typical longitudinal ulcers, gallstone appearance, and perianal skin tags and perianal abscess. And if diagnosis delays, we can find the stricture or penetrating complication like these endoscopic features. We have the various features of the inflammation, including very small ulcers and geographic ulcers and typical longitudinal ulcers. This is showing the various features of longitudinal and geographic ulcers in Crohn's disease involving colon and small intestine. Cornerstone appearance can be found in very severe Crohn's disease cases, but it is not pathognomonic for Crohn's disease, When we do an endoscopy, we have to check the perianal problem because we can find the very severe perianal involvement in some cases of Crohn's disease. Differential diagnosis with TB is very complicated and very challenging in some cases, but there are key differences between Crohn's disease and intestinal TB, including transverse ulcers in TB, petulous IG valve, and very frequent scar change compared with Crohn's disease. Previously, we had a problem of misdiagnosis of Crohn's disease as intestinal tuberculosis. And so many patients was misdiagnosis as intestinal TB. And I think that it would be the problem in the Vietnam as well. But in these days, we have more cases with intestinal TB and misdiagnosis with Crohn's disease. And this is important because TB can be cured with anti-TB therapy, but Crohn's disease requiring lifelong treatment with immunomodulators. It is not easy to differentiate between two diseases, but generally speaking, abdominal pain, weight loss, and diarrhea, rectal bleeding is slightly more common in Crohn's disease. And perianal disease is much more common in Crohn's disease. There is some few cases with perianal abscess by TB, but most cases with the perianal abscess is Crohn's disease, I think. And we also have to check the TB in other areas of body, including lung and peritoneum, etc. When we're looking at the cases of Crohn's disease, initially misdiagnosed with intestinal TB in our center, patient age was younger, and the median age was 23 years, and the diarrhea was dominant, and patient with asymptomatic presentation was very, very rare. And finally, patient finally diagnosed with intestinal TB had more cases with without any symptoms compared with the biennial Crohn's disease group. As I mentioned before, active perianal fistula was more common in the biennial Crohn's disease, and active TB was observed in about 13% of biennial intestinal TB group. Old TB was observed in about 1/4 of the biennial ITB group. Because endoscopy is crucial, we have to differentiate between two diseases focused on the features favoring Crohn's disease in left side and features favoring intestinal TB in right side, like purer than 4-segment involvement, transverse ulcers, petulous ileocecal valve, and scars or pseudopolyps. We can differentiate between two diseases over about 90% of cases. In addition to endoscopy, we can utilize chest X-ray and abdominal imaging because typical Crohn's disease show the skipped pattern of the longitudinal ulcers, but it is not common in Crohn's disease. And abdominal lymphadenopathy is more common in intestinal TB, especially caseous necrosis. Histology and microbiology can be helpful in some cases, but the K18 granuloma or AFB and culture positivity is usually not so common, especially in our data, it was less than 20% of cases. TB PCR, interferon gamma assay, ASCA can be helpful, but in less than 50% of cases. So it is not easy, but we have to combine everything to make a proper diagnosis. And this is our algorithm for the diagnosis of the Crohn's and TB. And we utilize the colonoscopic features here And we also utilized ESCA and small bowel involvement, especially proximal small bowel involvement, more common in Crohn's disease. And for TB, positive quantiferon TB test, and pulmonary TB findings was more common in intestinal TB. And when we combined these features and laboratory radiologic findings, we could make a correct diagnosis of the Crohn's or TB in almost all cases. Upper GI involvement is not so common, and in the guideline, EGD is not essential for making diagnosis of Crohn's disease, but I would like to recommend to do an upper GI endoscopy for proper staging of Crohn's disease and proper classification of Crohn's disease, because the upper GI environment has very poor prognosis, and some patients have the already structuring or penetrating upper GI features, and in these cases, we have to make a more aggressive treatment. And in some cases, a patient needs dilatation therapy or the surgery in the early course of the diagnosis. Capsule and enteroscopy is not so commonly used for early diagnosis of Crohn's disease, but capsule endoscopy can be used in well-selected patients with a very high suspicion of Crohn's disease. And it can be used to make a proper diagnosis of small bowel Crohn's disease, who cannot be properly diagnosed after ileal colonoscopy and small bowel radiologic examinations. DBE can be utilized at the biopsy of lesions and for therapeutic approach, but it is not so commonly used in Korea as well. A typical virus capsule endoscopy findings of Crohn's disease like this, but the gold standard criteria is not so established. I heard that the CTE and MRE is limitedly used in the Vietnam, but if we use these modalities, we can find the typical findings like longitudinal ulcer in the mesenteric borders of the small bowel intestine like this. And we also see the features of complicated Crohn's disease in CTE, and the complicated picture, especially in the perianal regions with MRI examinations. Small bowel follow-through is not so commonly used in Korea, like Vietnam. And if we do this examination, you can see the longitudinal ulcers and cobblestone findings. Same picture can be shown in the CT enterography, and you can see the enteroenteric fistula in these advanced cases of Crohn's disease. And sometimes if the diagnosis is not so clear, we may need a surgical approach at the initial diagnosis of Crohn's disease. And it is a problem that in some cases of Crohn's disease with a very acute presentation, patient go to the surgical clinic, and that patient is misdiagnosed with acute appendicitis, and the appendectomy is performed. And after appendectomy, patient do not getting well. So finally, the patient have complication and post-op complication, and finally the patient sometimes diagnosed with Crohn's disease. And if we do a surgery for Crohn's disease patient, we can find these features, including mesenteric pad lapping, advanced cases intestinal strictures of enteroenteric fistula. This is a very typical picture of the mesenteric pad lapping in Crohn's disease patient. I think that it is important for physicians to make a correct diagnosis for Crohn's disease, but it is also important for the surgeons, general surgeons, or the bowel surgeons have a proper knowledge on the diagnosis of Crohn's disease. Histopathology is not gold standard. It is supporting It is supporting diagnosis of Crohn's disease. And there is some typical features for some diseases like a non-cageating granuloma for Crohn's disease. And if we find the cageating granuloma or AFB, we can make a diagnosis of intestinal TB. And some other findings like CMV, MAB colitis, and PMC. If we find these pathologic features, it is more easier to make a diagnosis of each disease, but it is not always the case. This is a surgically resected specimens of Crohn's disease showing the longitudinal ulcers and strictures. And pathologically, it can show the transmural inflammation and granuloma and the patchy nature of the inflammation. But non-cageating granuloma is not so common, and it is observed in less than 50% of cases. And I'd like to stress again, the pathologic diagnosis is supporting, and clinicians' high suspicion of Crohn's disease is more important. Differential between ITB and Crohn's disease, as you know, the confluent granuloma, large granuloma, some mucosal granuloma, and high numbers of granuloma is more common in intestinal TB compared with Crohn's disease. Differential diagnosis, I'd like to show some cases briefly. This is an old female patient with lower abdominal pain, and she had intermittent hematochezia and weight loss, and she had a hypertension and angina. And this is a pictures of the colonoscopy showing inflammation in left-sided colon. Pathologic finding was not so helpful. And this patient actually referred to our hospital with impression of Crohn's disease. CT showed the inflammation relatively limited to left colon, and ileocecal area was okay. So this was finally diagnosed with ischemic colitis. And this is old woman. And old woman means that there is a low probability of Crohn's disease actually. And she had on multiple risk factors with ischemic colitis. Endoscopic picture was also suggested ischemic colitis. Radiologic features as well, including endoscopic findings and location of inflammation. So this patient was observed, and the patient finally improved and normalized. If we see this type of inflammation, we have to check the patient history of medication detailed. This patient of long-term NSAID taking history and NSAID-associated enterocolitis was binary diagnosis. In advanced cases, we can find this type of the fibrosis and circular fibrotic change of bowel. This is another cases of the 49 female patient with hematochezia, and she had recurrent bleeding requiring embolization. At another hospital, she was diagnosed with Crohn's disease, and steroid and azathioprine and infliximab was given, but she visited our hospital because of recurrent bleeding. And this is the endoscopic picture of this patient. This patient was finally diagnosed with a T-cell lymphoma, and it is not easy to make a proper diagnosis in this type of cases, but we have to have a high index of suspicion for this type of cases. This is another cases of male patient in age 50. This patient had febrile sense, weight loss, loose stool, and low abdominal pain. This patient was also diagnosed with Crohn's disease in other hospital, but as you can see in these colonoscopy pictures, this is not so well comfortable with Crohn's disease, and this patient have very bizarre types of the multiple ulcers in the whole area of the colon. Small bowel, double bowel enteroscopy also show the very bizarre shaped geographic ulcers all of the small bowel. And CT show the multiple lymph node enlargement in the abdomen. Finally, this patient also finally diagnosed with T-cell lymphoma associated with chronic active EBV infection. Crohn's classification of ileocolonic lymphoma was published in our hospital about 20 years ago. They can show the fungating nature or infiltrative nature, also fungating feature or infiltrative feature. In some cases, shows ulcerative lesion like this. And in these cases, we can misdiagnose these cases Crohn's disease, but please remember that we have to combine every feature, including CTE and the biopsy and patient presentation for making a proper diagnosis. What is the practical tips? It is also difficult in Western areas, and this type of the study was performed in Italy. And they developed on Redplex index for early diagnosis of Crohn's disease. And the important feature was you can see in the yellow box, non-healing or complex perianal fistula abscess or perianal lesion, highly suggestive of Crohn's disease. Family history of IBD also highly suggestive Crohn's disease. Weight loss 5% or more in the last 3 months, chronic abdominal over 3 months, and nocturnal diarrhea, highly suggested Crohn's disease. And I would like to emphasize that the detailed history taking is very, very important in the initial stage. But in the general physicians, the sensitivity of specificity of the Redplex index was not so high. And if we combine fecal calprotectin with Redplex index, we could enhance the sensitivity of specificity, especially specificity of diagnosis of Crohn's disease. So high index of suspicion by physician plus fecal calprotectin is important. If fecal calprotectin is not available, you need to recommend colonoscopic evaluation and radiologic evaluation and basic blood lab for diagnosis of Crohn's disease. This is my final slide. We have to remember that Crohn's disease is a progressive disease leading to accumulative intestinal damage. And if intestinal damage develop, many drugs like anti-TNF agent, anti-interleukin agent, and anti-integrin agent does not work so well for Crohn's disease patient. So we have to make an early diagnosis and make an early treatment before development of advanced diseases. Diagnostic delays increase risk of bowel stenosis and intestinal surgery in patients with Crohn's disease. So early diagnosis is key in the proper management of Crohn's disease. We clinicians should combine every clinical features, clues, and workup result for correct diagnosis of Crohn's disease. And I would like to emphasize you need to make a special focus on the perianal manifestation in early manifestation of Crohn's disease, and some patients, some small proportion of patients with ileal early involvement, which can be misdiagnosed as irritable bowel syndrome. So finally, we are having AOCC and international meeting of CASID in April this year. And this is the homepage of the AOCC. And abstract submission deadline is 27th this month. And pre-registration is the deadline is the end of February. And I would like to invite all of you to submit abstract and make a registration for this meeting. Thank you for your kind invitation. Thank you.
Thank you very much for your lecture from Professor Ye. I think that's your lecture very interesting and very useful for all doctors in Vietnam. After here, we have some discussion and question for you. Thank you very much for your presentation. Như vậy thì chúng ta đã cảm ơn cái bài trình bày rất là chi tiết của giáo sư Ye về những cái thực tế ở trong lâm sàng, đặc biệt là những cái kinh nghiệm của giáo sư bên Hàn Quốc trong vấn đề.
So we have learned very interesting presentation from our South Korean professors, especially the diagnosis for IBD in general and Crohn's disease in particular. And now I would like to invite Associate Professor Seong Joon professors from Seoul National University College. He is a member of CASIC and members of Korean Society of GI Endoscopy. He got more than 80 publications. He's gonna share about the new trends in choosing biologics for Crohn's disease.
Lecture update new trend and choosing biologics for optimizing for long-term outcome for Crohn patient. I invite Professor. Thank you.
Thank you for inviting me as a speaker for this symposium. I'm Seong Jun from Seoul National University, Korea. Today my talk is update new biological positioning in patients with Crohn's disease, and then I will share some cases who treated with ustekinumab. IBD, most commonly categorized as Crohn's disease and ulcerative colitis, are defined as chronic and inflammatory disorders of the GI tract characterized by abdominal pain, diarrhea, and hematochezia. Patients with IBD show alternating symptoms of disease relapse and remission, resulting in disease progression. The incidence of IBD in Korea have continued to increase over the past 3 years. This slide illustrates the 30-year change of IBD incidence in the Songpa, Gangdong area, South Korea. You can see that the age and sex-adjusted incidence have progressively increased over the study period. IBD is a Western disease, so the prevalence of IBD is very high in Europe and North America. In addition, the incidence and prevalence of IBD is rapidly increasing in newly industrialized country, increasing Korea. In developing country now, the prevalence is relatively low. However, shortly, developing country, including Vietnam, have a similar epidemiology in the prevalence and incidence of IBD in the near future. The mechanism underlying the development and pathophysiology of IBD still need to be fully understood. However, complex interaction between the host and luminal factors are involved. Substantial progress in the pathogenesis of IBD has been achieved, which lead to the development of new therapeutic target for IBD. You know that conventional treatment using corticosteroid or immunomodulators cannot modify this progression in patients with Crohn's disease. However, the use of anti-TNF agent induce mucosal healing, which reduce the risk of surgery and post-operative recurrence. So we believe that TNF pathway is considered an effective target for disease modification in patients with Crohn's disease. Over the last 20 years, more information regarding the effect of anti-TNF agents has been evident. However, there are some issues regarding a loss of response and sometimes primary non-response. In addition, adverse events such as infusion reaction and can develop in 20% of IBD patients. So there are great need to develop new agent involving other immune pathway in patients with IBD. Recently, a substantial progression in mucosal immunology of IBD has been achieved. The classic Th1 and Th17 pathway has been modified because of the identification of Th17 and Th19 cells. In addition, innate lymphoid cells has been identified as immune moderators, and molecular mechanism regarding the T cell migration has been intensively studied, contributing to the development of a new therapeutic target in patients with IBD. Treatment vedolizumab is a monoclonal antibody to integrin alpha beta 7. So this can block T cell migration to the intestine. Treatment with vedolizumab was effective in inducing and maintaining a remission in patients with UC&CD. In addition, no case of progressive multifocal leukoencephalopathy has been reported, so contributing FDA approval in 2014. GS.TS.BS is a monoclonal antibody to P40 molecule, so this can block both IL-12 and IL-20 pathway. A phase 3 trial was performed to evaluate the effect of GS.TS.BS in patients with Crohn's disease, including some patients who exposed to TNF agent. The primary endpoint was the clinical response at week 6 of induction trial and clinical remission at week 44 in maintenance trial. As shown here, GS.TS.BS was effective in inducing remission regardless of TNF use and maintenance trial. This is the result of Unity long-term study. During the 252-week, a third of Crohn's disease patients can maintain clinical remission using GS.TS.BS with 8 to 12 weeks interval. So GS.TS.BS is an effective and safe agent in patients with Crohn's disease. Risankizumab is a monoclonal antibody to P19 molecule, so this can block IL-23 pathway selectively. A phase 3 trial was performed to evaluate the effect of risankizumab in patients with Crohn's disease, and as shown here, risankizumab was effective in inducing and maintaining remission regardless of the prior use of other biologic agent. Guselkumab is another P19 monoclonal antibody. Recently, the result of phase 2 trial was reported in gastroenterology, and as shown here, guselkumab was also effective in inducing remission in patients with Crohn's disease. So now we have infliximab and adalimumab, vedolizumab, and GS.TS.BS in patients with Crohn's disease. We will have much more agents because some agents are on the phase 2 or phase 3 trial. You know that ozanimod is a S1P receptor modulator and was effective in inducing and maintaining remission in patients with ulcerative colitis. And now phase 3 trial for CD is still ongoing. In addition, we can use infliximab and adalimumab biosimilar. So I think that we can use 10 more biologic or small molecular agent in the next 5 years. This is the data from IBD fact sheet by Cassid. This slide shows the trends of drug use in patients with Crohn's disease in Korea. As you can see, the use of immunomodulators slightly increased up to 60% of Crohn's disease patients, and the use of steroid slightly decreased. Surprisingly, the use of biologic agent has been rapidly increasing. So now a third of Crohn's disease patients use biologic agent to control their disease in Korea. Next, I'll talk about therapeutic strategy in patients with Crohn's disease. IBD is a progressive disease resulting in some complications such as stricture, fistula, and abscess. So the ultimate therapeutic goal is to reduce bowel damage and prevent complication and to improve quality of life. To achieve this goal, tight control and monitor of intestinal inflammation has been suggested. This slide shows the therapeutic strategy in patients with Crohn's disease. The first T2T approach for tight controlling and monitoring of intestinal inflammation has been suggested in the updated STRIDE 2 guidelines. In addition, early intervention, the resolution of intestinal inflammation early in the disease course using a top-down or accelerated step-up is very important to reduce bowel damage in patients with Crohn's disease. And finally, personalization using the prediction of disease progression is becoming one of the main strategy in patients with Crohn's disease. So these strategies can reduce intestinal damage, bowel-related complication, bowel surgery, and hospitalization, and to improve quality of life in patients with Crohn's disease. The concept of T2T is very essential because treatment based on symptomatic response alone is maybe insufficient to prevent future complication. The general approach of T2T involves beginning with a baseline assessment and establishing the treatment target, and then a regular assessment of this activity using a clinical, biochemical, and colonoscopy or imaging study allows clinicians to continue current treatment or optimize current treatment. This slide shows the treatment goal of IBD. You know that treatment goal in IBD is rapidly evolving. Mucosal healing is the best established treatment target in patients with Crohn's disease. Recently, deep remission, histological remission, and transmural healing has been suggested as the treatment target in patients with IBD. So an important question is the timing and frequency to monitor non-response to therapy or to confirm the resolution of intestinal inflammation in patients with Crohn's disease. This figure shows the STRIDE 2 guidelines. So symptomatic response has been proposed as short-term treatment target, and symptomatic remission and normalization of CRP and decrease in calprotectin has been suggested as intermediate target. And finally, endoscopic healing, normalized cure, and absence of disability has been proposed as long-term treatment targets. So we have to monitor these time-dependent treatment target are reached, and we have to consider treatment optimization if the targets are not reached in appropriate time. This slide shows the protocol of CALM study. A CALM study demonstrates that clinical and management based on symptom alone show the low rate of mucosal healing and compared with one based on composite strategy using clinical symptom and biochemical markers, including CRP and fecal calprotectin. The primary endpoint of CALM study was mucosal healing assessed by CDEIS. So these figures show that the tight control and monitoring group showed higher rate of mucosal healing compared with clinical management group. Next, I talk about early intervention using biologics. A top-down trial was performed to evaluate the effect of early combined immunosuppression using infliximab and azacitidine. 133 moderate to severe CD patients were enrolled in this study and divided into two groups, early combined immunosuppression and conventional treatment. The primary endpoint of this study was the steroid or biosurgery-free clinical remission at week 56 and week 52. As shown here, early combined immunosuppression was more effective than compared with conventional treatment group. CHARM trial was a pivotal study to prove the effect of adalimumab in patients with Crohn's disease. In addition, post-hook analysis suggests that shorter duration, less than 2 years after diagnosis of Crohn's disease was a significant predictor for long-term remission for 3 years. So these data suggest that early intervention using a biologic agent can modify this progression in patients with Crohn's disease. Next topic is personalization. You know that UC and CD are very heterogeneous condition. So some patients of CD have a benign condition, benign disease course, while approximately a third of CD shows very aggressive nature. So this early intervention or aggressive monitoring is helpful in this group, and conventional treatment or monitoring is appropriate in this group. A recent review suggests that this activity and this severity should be evaluated in patients with Crohn's disease at diagnosis. This activity is the burden of inflammation at any given point in time, and this severity is helpful in determining a prognosis and predicting a complication in patients with Crohn's disease. Using the severity and activity, we can evaluate the future risk of this progression. I'm sorry. Can I see my slide? Okay. So using according to the risk stratification and clinical features, and we can choose the best treatment option in patient with Crohn's disease. In Crohn's disease patient who has severe or extensive disease, or proximal disease, stricture, fistulizing disease, or perianal disease, we can choose a TNF inhibitor with or without immunomodulators. Okay. In moderate CD, when limited to coronary disease and with no high risk features, we can choose risankizumab and vedolizumab because of the better safety profiles. Next, I talk about biologics positioning in patients with Crohn's disease. This table shows the Korean guideline for the biologics use in Crohn's disease. This guideline was published in Intestinal Research last year. Now we can use infliximab, adalimumab, vedolizumab, ustekinumab, and anti-TNF biosimilars in patients with moderate to severe CD who are refractory to or intolerant to conventional treatment. And also we can use them in maintenance treatment. However, we could not make a specific recommendation for biologic positioning because of the need of more clinical evidences. So personalized approach is very important when choosing biologics. So biologics positioning relies on numerous factors. So we usually consider efficacy, safety, extraintestinal manifestation, and convenience, and sometimes drug cost. This is the result of the CB study. The CB study was the first head-to-head trial comparing biologic agent in patients with Crohn's disease. 386 biologic-naive Crohn's disease patients were enrolled in this study and then divided into two groups, adalimumab group and ustekinumab group. The primary endpoint was clinical remission at week 52. As shown in this table, there was no significant difference in clinical remission at week 52 between the two groups, and no other significant findings were observed, including clinical response and endoscopic remission. This table showed the result of adverse event between the two groups. There was no significant difference in adverse event between the two groups. However, ustekinumab showed a low discontinuation rate during the study compared with the adalimumab. So based on this data, both adalimumab and ustekinumab have a great efficacy in biologics-naive CD patient. However, ustekinumab may have better safety profile compared with adalimumab. This is a result from a recent meta-analysis, including risankizumab. Infliximab combination treatment with infliximab and thiopurine showed the best efficacy in clinical remission in patients with Crohn's disease. However, ustekinumab have a similar efficacy compared with infliximab with or without immunomodulators. Active tuberculosis or latent infection should be evaluated in Korea because the prevalence of TB is relatively a little high in Korea. TNF inhibitor is associated with an increased risk of TB reactivation. However, vedolizumab and ustekinumab have lower risk of developing TB reactivation. In addition, we usually consider patient age, malignant disease, and viral hepatitis or some opportunistic infections such as CMV or CDPC infection. And so we believe that vedolizumab and ustekinumab have better safety profile compared with anti-TNF agent. Extraintestinal manifestations are common in patients with IBD. We can see some uveitis, psoriasis, and ankylosing spondylitis in patients with Crohn's disease because they share genetic, immunologic, and environmental risk factors. TNF pathway is very important in immune-related disease. So TNF inhibitor showed efficacy in RA, IBD, psoriasis, and ankylosing spondylitis. In addition, P19 and P40 monoclonal antibody, including ustekinumab, showed efficacy in both psoriasis and IBD. So we can choose ustekinumab in Crohn's disease patient with concurrent skin disease such as psoriasis. Convenience or preference is also important because Crohn's disease patients are relatively young and socially very active. Infliximab is an IV medication with 8-week intervals for maintenance treatment. So patients should stay in the hospital for 2 more hours. However, infliximab biosimilar can be administered subcutaneously with 2 weeks interval. Adalimumab also can also be administered subcutaneously with 2 weeks interval. Vedolizumab is an IV medication with 8 weeks interval. Ustekinumab is the most convenient agent after IV induction. Ustekinumab can be administered subcutaneously with 8 to 12 weeks interval. The cost, this table shows the frequency of biologics use between Western Europe and Eastern Europe. As you can see here, the frequency of biologics use is more frequent in Western Europe compared with Eastern Europe. And biologics-related cost is rapidly increasing after the diagnosis of Crohn's disease. So cost is very important when choosing a biologic agent. Biosimilars are a biological product that is highly similar to a reference product. There was no clinically meaningful difference in terms of safety, purity, and potency. Switching from the originator to a biosimilar in patients with IBD is acceptable following an appropriate discussion between physician, nurse, and patient. In Europe, average biosimilar price have been 30% lower than the reference product. This is the last slide in summary and conclusion. Crohn's disease is a progressive disease which lead to some complications such as stricture, fistula, and abscess. Early intervention, personalization, and T2T strategy with tight monitoring are very important to improving long-term outcomes in patients with Crohn's disease. Physicians should consider the patient preference, cost, adherence, safety, and speed of response to the drug when choosing a biologic agent. Next, I show some cases. We have 58 Crohn's disease patient who treated using ustekinumab. Approximately 70% to 80% patients show clinical response or clinical remission after using ustekinumab in the real world practice. This is the first case. The first case was a 50-year-old female. She had past medical history of pulmonary tuberculosis. She was diagnosed as Crohn's disease in 1993 and treated with conventional agent, including steroid. She got surgery, first surgery in 2002 because of perianal abscess. Infliximab was the first biologic agent and started in 2012 to control intestinal and perianal inflammation. She got second surgery due to perianal fistula in 2015. Second biologics, vedolizumab, was used to control inflammation in 2019, and then vedolizumab dose escalation was done in 2020. However, symptomatic similar improvement was not achieved after the high dose of vedolizumab. So ustekinumab induction was done in 2020. After the induction of ustekinumab, symptomatic improvement was achieved. This is the photos of colonoscopy before and after the use of ustekinumab. As shown here, multiple longitudinal ulcers and pseudopolyps were found before the use of ustekinumab. You can see that nearly mucosal healing was achieved after the use of ustekinumab. This is the second case. Second case was a 50-year-old male. He had no specific past medical history. He was diagnosed as Crohn's disease in 2018 and treated with conventional treatment, including steroid. First biologic agent was also infliximab in 2018, and dose escalation was done in 2019. And mucosal healing was achieved in 2020. However, a loss of response was developed in 2021. So induction treatment using ustekinumab was done in 2021. After the treatment, symptomatic improvement was achieved, and mucosal healing was also achieved after the use of ustekinumab. This is the last case. The last case was 36-year-old female. She had no specific past medical history. She was diagnosed as Crohn's disease in 2013, and she used conventional treatment. In 2018, symptom aggravation was observed. So conventional treatment was done. However, there was no response after the conventional treatment. So induction treatment using ustekinumab was done in 2019, and symptom improvement was achieved. And then we can see a mucosal healing after the use of ustekinumab in this patient. Okay, thank you for your listening. I hope to see you in AOCC in 2023 in Busan. Thank you.
Thank you very much for your lecture. Như vậy thì báo cáo với lại các quý thầy cô, như vậy là cái buổi báo cáo của ba chúng ta đã nghe cái ba báo cáo viên
So
rồi.
we have enjoyed the three presentations. And now we will continue with our discussions. We prepare the chairs on the stage. We would like to invite Professor Ye, Professor Cole, Dr. Luan, and other panelists to get on the stage. We also have Associate Professor David Hằng. She will provide direct interpretation. So please prepare a microphone for direct interpretation. I would like to invite our panelists and speakers to get on the stage.
Như vậy là chúng ta là bây giờ là đi gọi cho nó 10 giờ đi. Như vậy là chúng ta thảo luận trong vòng đúng 1 tiếng. Như bây giờ đúng là 9 giờ 58 phút. Chúng ta sẽ thảo luận trong vòng 1 tiếng đến 11.
We're gonna have 1 hour for discussions sharply.
Chúng ta sẽ 11 giờ chúng ta sẽ làm tổng kết. Đề nghị phía dưới chúng ta ai có câu hỏi chúng ta sẽ hỏi nhé, hỏi trực tiếp luôn.
We invite questions from the floor, direct question. We're gonna send microphone to you.
Now is a question and discussion and answer. I invite Professor Yi, Professor Ko, and Dr. Luan go to here, and I invite Dr. Bình, Dr. Hoàng, and Dr. Hằng. Hằng. Anh Long, vâng, xin mời Dr. Long. Okay. Xin mời Dr. Yi. Dr. Ko here. Anh Bình, đi. Vâng, Lên đi. Bây giờ phía dưới ai có câu hỏi thì chúng ta sẽ hỏi trực tiếp luôn ạ.
We invite direct question from the floor.
Cần đâu đây có chị Hằng, chị sẽ phiên dịch cho luôn rồi, không cần đâu ạ. Vâng. Anh Bình, trước hết thì bây giờ thế này, chúng tôi sẽ lần lượt tất cả mọi người đều có câu hỏi.
So we will take turn. Mr. Bình will share his comments first.
Kính thưa Phó giáo sư Khien,
Associate Professor Kim,
các chuyên gia,
distinguished guests.
thì vừa rồi chúng ta đã nghe
So we have listened to the three excellent presentations.
của bác sĩ Luan.
The presentation by Dr. Luan,
Một cái tổng quan.
he shared in general about the challenges in Crohn's disease diagnosis.
Có rất nhiều những cái thách thức.
There are many involved challenges. And in general, what are they? We have challenge from patient perspective, doctor's perspective, and equipment perspective. When we look at patient challenges, when patient they have IBD or in particular Crohn's disease, they don't have proper understanding. So the definition show that we have wax and wane feature. So that's why when patients come to doctors, they tend to be overconfident with just initial response to the first prescription. So they reuse that prescription. They don't come back to doctors anymore. So in certain places we have problem with culture. For example, in mountainous area, patients found it very difficult to travel long distance to specialists. And another challenge from doctor perspective is that we have many different specialties, especially in the primary care setting. We don't have specialists. Therefore, doctors tend to overlook, tend to miss IBD patient. Sometimes we treat those patients like just a simple GI disorder. And patients, they may not comply with reappointments. So, and doctors may lose patients to follow up. And right now, we don't even have gold standard for IBD diagnosis. So it is even harder. So without gold standard, we may misdiagnose with other diseases, or And another problem is about equipment. Not every medical center could have adequate equipment, especially in remote areas. Patients may not travel. They couldn't travel very far, and locally they don't have endoscopy, or they have very poor quality of endoscopy, or the lack of CT scan, the lack of X-ray. And even in major hospitals, sometimes they don't have proper pathology. And the second presentation by our South Korean professors, the experience in treating Crohn's disease with biologics. The presentation by Professor Cole. When could we stop biologics? And what should we do before we stop biologics? Professor Cole, the question is for you.
Professor Cole, yes, you have a question. Yeah, when to stop biologics and what do we have to examine before stopping biologics?
Okay.
Thank you for nice question. Your question is about stopping biologics. In Korea, we do not usually we do not consider stopping biologics because the symptomatic or intestinal inflammation can be aggravated when stopping anti-TNF agent. But we can consider in some case we can discuss patients about stopping biologics, and we could stop therapy using biologic agent, but we should keep the monitoring using symptom or biochemical and colonoscopy or imaging study in regularly. Okay.
Professor, so just in some case that we could consider of stopping, so in which case and for how long we have to monitor? Because in case you say that for the most people we will not stop, but in some case we can consider. So in which case you will consider?
So it's not, it's very difficult question, but I think that we can consider stopping biologics. The patient is very stable. Stable means that a patient reach deep remission, such, for example, in UC case, patient reach historical remission, and we can discuss regarding the stopping biologic agent, and in some case of CD who reached transmural healing and mucosal healing. And so we think that these patients are very stable, so we can consider stopping biologics in these patients.
Thank you. Cái câu hỏi này thì của một bạn đồng nghiệp của bác sĩ Bình rất hay, là đang nói là khi nào mình ngừng được thuốc sinh học và phải theo dõi gì, thì giáo sư cũng có nói là
The excellent question. When could we stop? He said in South Korea, they rarely consider that only for special case, and patient must have very sustainable response, especially histological response. For UC and for Crohn disease, we must have transmural healing, mucosal healing. Then we could consider stopping. We may consider stopping. They monitor based on biochemical testing, endoscopy, and symptoms. Comments from you or question? Good morning, everyone. Good morning, distinguished speakers. I would like to make some comments. My first comment is why in Asia and in Vietnam, why we have significant increase in IBD? Obviously, we are seeing more and more patients, especially with complication. Patient with Crohn disease, we have to ask ourselves why this disease was rare in the past, but now it become more and more common. Maybe because of the change in our lifestyle, the change in our diet, the change in our living environment. So maybe we have the changing impact on the mucosa. And in patients with deposition risk factors, patient may develop IBD. In the past, this disease was rare. It was rare. Therefore, doctors didn't have much knowledge about this disease. Sometimes patients came to us very, very early, but we diagnosed with IBS or just some like non-specific colitis. Therefore, patients don't receive adequate treatment, proper treatment. and eventually they develop severe complication. So when they get to major hospital, they already have very bad, very terrible complication. So I think we should include IBD teaching in curriculum. In the past, we didn't have IBD teaching for students, for medical students. So we have to start this initiative. We have to start teaching about IBD in medical curriculum for graduate or postgraduate students. That is my comment. And we learned that this is a challenging disease, so we need collaboration, real collaboration among different specialists. So we need IBD team to facilitate collaboration so that knowledge from each specialist will help us to come up with proper diagnosis and proper treatment. That is my comment, my thinking when I listen to multiple speakers. And I have a question for Professor Ye. Professor Ye, could you share about the role of genetic screening for IBD, in particular CD? Is that important?
Thank you for the question. You mentioned about genetic screening.
Yeah, genetic screening.
Actually, we don't know exact genetic structure of Crohn's disease patient. As you know, the more than 200 genetic loci is associated with the risk of Crohn's disease, but Crohn's disease and ulcerative colitis is not a monogenic disease, and multiple genes are associated with development of Crohn's disease, and they are interacting with some environmental factors. So the answer is there is still no genetic screening tools for diagnosis of Crohn's disease, but there are some candidate genes for predicting the poor course of Crohn's disease, but for diagnosis itself, genetic tests does not be helpful for the Western patient and some patient as well, all over the world. That's my answer.
Xen kẽ thì chúng tôi sẽ cứ xen kẽ. Có một cái tôi trong cái bài của Luan,
Professor Dr. Luan and Professor Ye, they share about accelerated it's set up stop down. We have accelerated step up. So could you explain further what is the concept of accelerated step up? Dr. Luan, you answer first, and Professor Ye will answer with additional comments. Thanks for your question. We know that we have step up and top down, the two different strategies. But like I mentioned, there are pros and cons of those two approaches. So in Asia, we have high risk of infection, limited resources, and we have risk of over-treatment if we use top-down. Therefore, we may consider accelerated step up, accelerated step up. We need to look at the poor prognostic factors. If patients they have poor prognostic factors, for those special patients, we could predict that they could develop irreversible lesion, irreversible damage. So for those patients, we should avoid gradual step up. We have to consider accelerated step up. If patients don't respond adequately, we should switch to stronger treatment instead of waiting. And the second question is, how long should we wait? Right now, we don't have proper timing. We don't have proper timeline, unfortunately. So we have to remember, for patients with high-risk features, we should be aggressive, should be quick with our acceleration, step up. Don't wait for too long for an effective treatment.
But that is very good and key questions. Actually, in Korea and in many Asian countries, top-down therapy is not so feasible because of the reimbursement issue and high cost of biologic agent as the first-line drug. And to be honest with you, actually top-down cannot be reimbursed in Korea. So we are utilizing the accelerated step of care for Crohn's disease patient. So in my practice, after diagnosis of Crohn's disease, we have to make a prognostication, and as Dr. Luan stated, and if patient have the poor prognostic factors like a very young age of onset, high inflammatory burden, SK positivity, extensive small bowel environment, high sharp, etc., we have to apply the accelerated step of care. In my position and in my practice, I'm checking the NUDT15 and TPMT for the detecting the therapeutic associated side effect earlier. And if patient have the wild type for both two genotypes, I am giving the diapirine agent in the high dose, like 2 milligram per kilogram per day for the patient. And after applying the diapirine therapy, we need to evaluate the response in 6 to 9 months after the diapirine therapy. And if patient have the deep remission, I mean the symptomatic, biochemical, colonoscopic, and radiologic remission, we can continue diapirine therapy if patient do not have any issues like side effect. But if patient have some sign of inflammation, even if the patient have no symptoms, for example, if patient have some inflammation in the evaluation or some high inflammatory marker, we need to go to the step up at that stage to the biologics. So in our study, actually, when we use the anti-TNF agent within 1 year after diagnosis of Crohn's disease, patient had a higher probability of achieving transmural healing in the long term. So I would like to recommend you to start the biologic agent within 1 year after diagnosis of Crohn's disease if patient do not show complete deep healing after diapirine therapy.
Dạ, xin phép có một cái câu hỏi ngắn, xin phép trước có tham luận vài dòng thôi, thì tôi cũng rất là đồng ý.
I
Xin
would
cảm ơn.
like to make some comments and a question. I completely agree with the three presenters. And the issues here in Vietnam and in hospital, we need IBD team to have a consensus with our treatment plan, especially when we have difficult case, so that we could come up with proper orientation to treat those patients, and even collaboration among different centers. We know that biologics are expensive, and the risk of side effects, the risk of complication are also significant. I would like to ask Professor Cole, according to literature, according to report, we have a case with pregnancy, patient with IBD, and they still have to use biologics. In Bạch Mai Hospital, Military Hospital, or UMC Hospital, we are the major hospital. So patients come to us when they already have very severe disease and they already receive biologics in the past. They may have underdiagnosis or improper treatment, under treatment before or over treatment before. So I would like to ask you, for pregnant women, which kind of biologics should we use? Could we use biologics, even though we say the risk of complication, the risk of side effect would be the same, just like general population? Professor Cole, what do you think? Professor Yi, Professor Cole, or Professor Yi?
I'm sorry. In Korea, so we have many complicating cases with Crohn. The same situation, and so it's very important to choose the proper biologics in these patients. So it's not easy, but as mentioned before, we should consider the personalization treatment when choosing biologics in patient with Crohn's disease. A patient with Crohn's disease who have some features, higher inflammatory burden or higher disease activity or the higher risk of disease progression, I usually use anti-TNF agent with immunomodulators in patient with Crohn's disease. But we have some another factor, another options in Korea in real world practice, including vedolizumab and ustekinumab and anti-TNF biosimilars. So, and we can enroll the city patient in some clinical trials. So we can choose some another biologic agent when considering the issues regarding safety or some another disease. We can choose ustekinumab or vedolizumab in this patient. So the another problem is that a patient who already exposed to anti-TNF agent maybe you can have some cases. So I have very little information about this case, but I usually use ustekinumab in this patient. I prefer to change mode of action to choose another anti-TNF agent. Okay. Pregnancy. Okay. Safety. Okay. Pregnancy is one of the factors when choosing biologics. Anti-TNF is the most safe agent in pregnant women. So we could consider anti-TNF agent who in pregnant women, but ustekinumab vedolizumab has little information about the safety in patient with in pregnant patient with Crohn's disease. So I usually recommend to use anti-TNF agent in pregnant women with Crohn's disease.
And you asked about the severe patient already exposed to biologic agent, and if that kind of patient referred to hospital, and what is my plan? Your question, right? Pregnancy. Pregnancy. Okay. Actually, as Professor Ko mentioned, anti-TNF is the most safe biologic agent, and the last dose of Humira can be 2 to 3 weeks before delivery, and the last dose of infliximab can be 6 to 10 weeks before delivery. And there is a limited evidence of the vedolizumab and ustekinumab, but the more and more data, recent data suggesting that the ustekinumab and vedolizumab are also safe during the pregnancy. So in my cases, if patient under treatment with ustekinumab or vedolizumab, and if she get pregnant, I keep the medication. I keep the medication till the delivery. But you know, the tofacitinib and MTX should be avoided before having a baby.
Because the concentration, the level of anti-TNF at the third trimester will increase. So some data show that we should stop the anti-TNF after in the third trimester. So like how long? Like at which or you still use it?
Yeah. In the recent practice, it continue anti-TNF medication even during the third trimester, but we have to be cautious about giving the vaccines to newborn. You know, rotavirus vaccine should be avoided, and BCG should be given 6 months after delivery. So I keep the medication until the delivery, but the caution should be given to the vaccination for newborn.
Thank you.
Vâng, kính thưa các thầy trong chủ tọa đoàn, tôi cũng thấy là ba bài báo cáo rất là hay và tôi cũng xin nhấn
So we
mạnh
enjoy 3 excellent presentations. I would like to emphasize again. I would like to emphasize again on the need for IBD team. That is at most important because the majority of Crohn patients come to us with late-stage disease, with existing complication. The majority of patients came to us with fistula, with stricture. So with the current numbers of ever-increasing Crohn disease patients, and some patients already use biologics. The limitation here is that patients come to us with late-stage disease, and biologics in Vietnam are very expensive, and social insurance only reimburse 50%. So we have limited use of biologics. We require long-term treatment here, even lifelong treatment. So I would like to ask Professor Ye, in your clinical practice, when we use biologics, for example, anti-TNF alpha, infection is a common problem, and we have to stop, we have to discontinue treatment. So could you share your experience for those patients with infection? And the second question here is in Vietnam, when we use biologics, in particular anti-TNF alpha, we have those drugs available, but we don't perform TDM, we don't perform therapeutic drug monitoring, we don't test for anti-drug antibodies. So because without TDM, we don't have much experience to escalate the dose, de-escalate. So those are the two questions for you. What should we do without TDM?
Okay. First question is infection issue with the anti-TNF agent. Actually, I think that cases of infectious cases with anti-TNF will be decreasing in the future. I think that many doctors are worried about the TB reactivation in Vietnam. Actually, it is 1 to 2% in Korea. And for the proper diagnosis of the treatment of infection, the most important one is the physician's high index of suspicion. And for the TB cases and pneumonia cases, we are seeing patients together with our pulmonologist. And the chest PA is checked before start of anti-TNF and 3 months after anti-TNF, 6 months after anti-TNF, and 1 year after anti-TNF, and every year after during the anti-TNF treatment. And if there is a high index of high index of suspicion of infectious disease, we are collaborating with a pulmonology or infection specialist. And after clearing of infectious issue, we can restart the same anti-TNF agent. And if the patient have the active IBD during the TB infection, we can start anti-TNF 3 or 4 weeks after starting a proper TB treatment. So I think that we do not so much worried about infectious complication in patients with Crohn's disease, because Crohn's disease activity itself is also risk factors for the infection itself. And the second one is a TDM of anti-TNF agent. And I think the first you should introduce the TDM test earlier in Vietnam. And if TDM is not available, I think that you have no choice but to make a decision depending on the patient's symptoms and the laboratory findings and radiologic and endoscopy findings. And if the doctor is very keen to patient status and have some experience on the patient monitoring, I think that reactive treatment strategy on the biologic titration is not so different from the outcomes based on TDM. That's my comments.
One question from the audience that should we use ustekinumab at first, or we can use when anti-TNF fail? And if we start with ustekinumab, is there any other benefits when we're comparing with anti-TNF?
In patients with failure after anti-TNF use, right? So there is very little data about the questions, so we can choose ustekinumab and another anti-TNF agent in Crohn's patient who fail to anti-TNF agents such as infliximab. Adalimumab was effective in inducing and maintaining remission after a failure to infliximab treatment, and ustekinumab showed the same efficacy regardless of the use or prior use of anti-TNF agent in patients with Crohn's disease, but there was no randomized control head-to-head trial comparing biologic agent in Crohn's patient who failed to previous anti-TNF agent. So, but I usually prefer to use ustekinumab because I want change the mode of action. So it's my in my opinion. So there is very little data, but he has more experience, so you can more information from Professor Ye.
First of all, I'd like to emphasize the initial choice of the drug. As Professor Go mentioned, if patients have very high inflammatory burden and high disease severity, actually, to be honest, anti-TNF is better, especially infliximab. But if patients have relatively lower inflammatory burden and relatively early disease, short duration of disease, I think that the ustekinumab can be selected as first-line therapy. As shown in the SHIV trial, the clinical remission rate was as high as 65% in the biologic-naive Crohn's patient. That kind of patient could be a very good candidate for first-line ustekinumab therapy. The second issue, the advanced patient, very advanced disease stage patient. In that cases, we have to cautious about the changing drug, because if we change the drug too frequently, there is no choice to that kind of patient in the future, because we have a limited number of biologics in our practice. So in that very kind of advanced disease patient, the treatment target is not deep remission. Treatment target is disease stabilization. So in that class of patient, even if the patient have some low degree of inflammation, we can continue that treatment, because the treatment target is not deep remission. So I would like to emphasize the biologic cycling too frequently is another misconduct of the doctors.
So thank you for the two presentations. So I have two questions for you. The first question is that regarding the maintenance dose of ustekinumab, do you use the dose of 90 milligram every 8 weeks or every 12 weeks? Because the study showed that 8 weeks and every 8 weeks, every 12 weeks have the same efficacy. So in clinical practice, do you use ustekinumab every 8 weeks or every 12 weeks in Crohn's disease?
I usually use ustekinumab with 12 weeks interval in naive CD patient as when I use the first-line agent. The ustekinumab as the personal agent, I usually use with 12-week interval. But in case of CD patient who fail to anti-TNF agent, I recommend to use ustekinumab with 8 weeks interval, and then I check the 1 year after the treatment colonoscopy, and I check the colonoscopy and MR angiography result, and I can use ustekinumab with 12 weeks interval or something.
Mostly same for me, and I think that if ustekinumab is just used as the second or third line therapy, in most cases we need every 8 weeks treatment in most cases, and even before 1 year, if after induction, if patient do not show complete biologic remission, like still high CRP or fecal calprotectin, I shorten the interval to every 8 weeks treatment. So in my practice, most of patients have the very severe disease, and most of patients are getting ustekinumab every 8 weeks.
And one more question is that we know that we use imlifidase. Usually we combine with the azathioprine. So the question for you is that when you use adalimumab, it's been Humira, or when you use Stelara, it's been ustekinumab, do we need to combine with the immunomodulator?
There were some conflicting results regarding your question. I usually I usually use adalimumab with immunomodulators at the initial times. So, and then the same practice. I check the follow-up result and consider reduce the dose of immunomodulators in patients with Crohn's disease. The ustekinumab is also little data about the question, but I usually recommend to use combination treatment at first, and then I check the therapeutic response 1 year after the treatment, and then I discuss about the discontinuation of immunomodulators with patient.
Bác sĩ Nga có câu hỏi phải không ạ? Bác sĩ Nga có câu hỏi không ạ? Vâng, bác sĩ Nga đứng đây hỏi đấy.
Thì em xin cảm ơn các bài báo cáo của các thầy.
We highly appreciate the presentation. Very meaningful, very helpful for me. I have a question. There are two questions to the two professors. The first question is, in Vietnam, the percentage of biologic users, I think we have higher prevalence of TB, of tuberculosis. So what are your experience, your regimen to treat latent TB? After you treat latent TB, what are the essential tests? What are the necessary tests to say we could now save with the latent TB, we could complete the treatment for latent TB? And the second question, in patients with post-operation complication, they have the time from surgery to the time of biologics. What is the interval between surgery and biologics? Thank you.
For latent TB issue, before every biologic use, we need to check the latent TB with interferon gamma saying GS.TS.BS and history. And in our hospital, we are using the isoniazid plus rifampicin treatment for 3 months for treating positive cases of latent TB. And after a proper INA plus rifampicin treatment for 4 weeks, we can start the biologic agent for that patient. And after the starting of the biologic treatment, we have to complete the latent TB treatment, and follow-up is performed in our pulmonology department. And after finishing the treatment, a patient is checked their symptoms and GS.TS.BS findings 3 months, 6 months, and then 1 year, and every 1 year after that. That's my practice. And the second one is a post-operative biologic therapy. Unfortunately, actually, if patient have a very high risk of the recurrence of Crohn's disease after surgery, it is recommended to a biologics agent if the patient was naive to biologic therapy. and evidence is still limited to anti-TNF agent. So in that cases, I would like to start anti-TNF agent for that patient, but the reimbursement is not possible in Korea. So after treatment, I keep the medication before surgery, like an immunomodulator therapy. And after 6 months of surgery, I fully evaluate the patient's status, including colonoscopy and lab, fecal calprotectin and MR angiography findings. And if that patient have any evidence of the recurrence in the colonoscopy over a Lutgert score I2 or over, I start the biologic agent for that patient. And the preferred biologic agent is anti-TNF. And there is accumulating evidence of the ustekinumab in the post-operative setting, but we need more evidence and data for the post-operative setting of the ustekinumab's efficacy.
Bình có câu hỏi.
I have a question for Professor Có. Vâng. Ở trong khoa chúng tôi thì chúng tôi đã gặp một cái bệnh nhân UC, điều trị UC.
In our department, we have an UC ulcerative colitis patient received treatment for a pretty long time. Initially, patient responded very well, but in the fifth cycle, patient developed more symptoms. In the fifth cycle, patient was diagnosed with CMV co-infection and maybe latent TB and also worm infestation. So in this case, could you share your opinion? Should we continue biologics or stop biologics, and which treatment should we favor?
A case about CMV infection.
And then have the infection of both CMV, TB, and parasite. So which one to prefer treatment?
We usually stop biologics in this case. It's not easy to see patients who have another infection. We can see CMV infection in UC patients in Korea. So usually we stop biologics because we cannot get insurance reimbursement in CMV positive patient with antiviral treatment. We should select antiviral agent or biologic therapy. So I usually stop biologic therapy in UC patient with CMV infection. And another occasion is about TB or some worm parasite. Parasite is parasite infection is very uncommon in Korea, so we did not consider any other parasite infection when using biologic agent.
Dạ thưa thầy thì không may là bên em cũng có một ca giống như vậy.
I got the same case exactly, just like your case. In my hospital, patient with UC, we have inclusion body. We detected inclusion body, but luckily my patient didn't have latent TB, but we do have worm infestation. So patient all of a sudden develop. We use antiviral 900 milligram vancomycin 900 milligram for 2 weeks, and we also use anti-worm treatment. Patient responded very well. Bowel movement got normalized. But later on, patient continued to relapse with symptoms. And when we continue infliximab, patient continue to relapse, but the worm disappear. We reperform biopsy to try to look for CMV, but it was negative. In that case, we changed to tofacitinib. Patient responded very well. Right now, patient receiving tofacitinib. Patient achieved endoscopic remission 6 months ago. In fact, the question is about infection, opportunistic infection in patient receiving anti-TNF. Actually, it is quite unique in Asian countries, especially tropical countries like Vietnam. So the warning is when we treat patient, after good response initially, patient develop abdominal pain and fever, then we have to consider infection. We routinely test for CMV, evaluate the stool, looking for worm infestation. That is very, very typical in Vietnam, especially when patients use steroid, patients use immunosuppressants, then they may develop worm infestation. So usually we use interleukin treatment, 2 dosage to manage this infestation, to eradicate the larva, eradicate the worm eggs. So we have to high suspicion index. Thank you. So just like Professor Hoàng and Dr. Luan shared with us, in my case, we treated our patient with antiviral treatment, anti-TB, and patient responded well, and we resume infliximab. We use ivermectin and gacilovir. We treat for 3 weeks, and afterward, we use high anti-TB, high dose anti-TB. Currently, patient is stable, and then we resume biologics. So we are almost out of the time. According to the agenda, I would like to ask our Korean colleagues that yesterday, when we discussed with Johnson & Johnson people, they sponsor for many IBD seminars, including Crohn disease seminars. So by the end of this year, we will have a local consensus to manage IBD, in particular Crohn disease in Vietnam. And the 2 authors would be Professor Bùi Hữu Hoàng and Dr. Đặng Minh Luan. So we want to learn from you, learn from your experience. I would like, I think you already have your local guidelines, your biologics consensus or biologics guidelines. So what is your experience to develop your local guideline? Because regarding testing in Vietnam, in order to perform testing for IBD patient in general, CD or UC in particular, we have much higher prevalence of infection. So in your experience, should we perform every available testing? For example, fecal calprotectin not always available, small intestine endoscopy, double balloon, single balloon, etc. And in your experience, what is the most common, most popular biologics in South Korea? Because right now, for example, ustekinumab in Vietnam, we want to include that in our guideline to serve our patient. So I would like to ask for your experience. In your guidelines for Crohn disease, we perform every available testing. And the second question is, what is the most popular biologics for Crohn's disease? Professor Ye, you go first, and then Professor Ko.
Yeah, it is not easy to cover all of the drugs and all of tests in your guidelines, but I think that as professors mentioned, you need to spread the doctors' focus on the inflammatory bowel disease regarding diagnosis and treatment first, and you have to select and invite potential experts for making that kind of guidelines first. And I think that it is not easy or possible to include every features of diagnosis of treatment in your guidelines. But basically, biologics should be placed in the every statement regarding their efficacy or effectiveness and safety, even if they cannot be reimbursed in your country. And if the guideline is set and the reimbursement of the kind of drugs can be easier for the IBD patient in your countries. And the second one is you need to be given more space, also more volume for your country's specific situation, as you mentioned, the infectious issues, the diagnosis of and the management of infectious issue in before diagnosis and during the treatment of inflammatory bowel disease. So that's my general comments. And the second question was most available biologics?
No, biologic drugs. What is the most biologic drug in your country?
I think that for Crohn's disease, anti-TNF is still most popular drugs, especially infliximab, and infliximab subcutaneous agent can be used. It's still most prevalent, most popular drug. And the second drug would be the ustekinumab, I think. And the third one may be the vedolizumab. And as you know, the vedolizumab works better for the UC compared with the Crohn's disease patient, generally speaking. And I think that more and more patients are getting the ustekinumab, and more and experience we are having in the treating the patient with the ustekinumab.
About guidelines. So I showed the biology guideline in my lectures. The guideline is the third guideline made by CACID in Korea. So it is very difficult to make a specific recommendation about making guideline is very difficult. It's a great burden to some clinician or some statisticians. So I think that if you want to make some guideline in Crohn's disease or ulcerative colitis, you better start with some part, for example, diagnosis or conventional treatment or biologic treatment. So you can make a step-by-step. You can do that step-by-step approach. So because it's very great, but so you need very many specialists to make a guideline, and you search a lot of papers and discuss a lot. So it's great burden. So you have to consider these difficult situations. So and biologics, Professor said before, and I totally agree with his opinion. So
I agree with the Professor Ko's comment, and I think that you should start with the diagnostic guideline first, and then you go to the therapeutic guideline after that. and you have to allocate the leader corresponding also corresponding also for that specific guideline, and yeah. and leader should have a big have a big burden for the making that guideline, but leader is a very important. And ideally every guideline should be based on the best available evidences, but in many areas evidence is very limited, and it is not so easy to make a very strict statistical analysis or statistical methodology. So it is also okay to start with experts consensus statement like that. Yeah, you can start with that kind of the easier one in the first stage, I think. Thank you.
Như vậy thì còn 5 phút nữa, nhưng mà vẫn có một bạn hỏi.
We have 5 more minutes, and a question for Dr. Luan. A question for Dr. Luan. People nowadays care a lot about Crohn's disease, and what is early timing to choose biologics? If we are late for the window of opportunity, then that is a pity. So what is your experience in choosing biologics in the early stage? Thanks for the question. This is a very common question. How to initiate biologics? How soon to say this is early intervention? Early stage is defined as within 18 months after definitive diagnosis and patient haven't received immunomodulators or biologics. So that is a definition of early stage Crohn's disease. Professor Ye also shared with us that Crohn's disease patient should receive biologics within 1 year. Within 1 year of definitive diagnosis. And studies also show us that if we treat patients within 2 years of diagnosis, then they will have better prognosis compared with patients receive treatment after 2 years. So the threshold is usually 18 months or 2 years. So early stage could be from 1 year to 2 years to consider biologics. Thank you for the answer. So the two professors, Professor Ye, Professor Ko, Dr. Luan, distinguished panelists, we have come to the end of our meeting. I would like to have some conclusion key points. I highly appreciate the first presentation by Dr. Luan about the current situation here in Vietnam with very high prevalence of infection. So it is very challenging to treat Crohn's disease. And you see, Dr. Luan and Dr. Ye show us that we don't have the gold standard to diagnose Crohn's disease. So to make accurate diagnosis, we need a team. We need MDT. We have subclinical experts, clinical practitioners, and other specialists to make diagnosis and come up with treatment plan. We highly appreciate Professor Ye, a very experienced, very prestigious professor, sharing us about differential diagnosis, especially for Asian patients in the Asia-Pacific region. And we recognize that Crohn's disease is a very complex disease. We may overlook diagnosis, and patients later on may develop very severe complications. Professor Ye shared with us the general overview of Crohn's disease diagnosis and treatment. And the third presentation by Professor Ko, we highly appreciate your sharing by showing us available biologics, especially ustekinumab, the anti-interleukin 12 and 23. This is very highly effective drugs, similar efficacy to the current anti-TNF alpha, but with less side effects, less complication. In December last year, we did have ustekinumab available locally, so hopefully we will soon have many more patients receiving ustekinumab. So those are the information we learned from the meetings. We highly appreciate the participation of Professor Kim, Professor Byong Duk from KC. KC members, and we also have some young doctors participating. We're gonna send our delegation to join your Busan conference, your KC conference. Hopefully in the near future, we're gonna have very close collaboration between our organization and KC South Korea. Many thanks to everyone, and especially the online and offline participants. We have come to the end of our conference. We wish you very good health. And now, Dr. Xuyến, our sponsor, will share a couple of words with us. Good morning, Professor Kim, our panelists, Professor Bùi Hữu Hoàng, Dr. Nguyễn Công Long, Professor Nguyễn Cảng Bình, Specialist Level 2 Hồ Tấn Phát, the three speakers, Professor Ye, Professor Ko, Dr. Luan, Korean delegates, online and offline participants. After more than 3 hours of intensive working and sharing, we learned a lot from our speakers and our panelists. With the chairmanship of Dr. Khien, our seminars was a great success. On behalf of Johnson & Johnson Vietnam, we want to express our sincere thanks to the leaders of VNAGE for working with us to facilitate such great seminar today. Speakers, panelists, thanks for your preparation and your comments, your answers, especially our colleagues from CACIT. Thanks for your time. Thanks for your long distance traveling. Hopefully, the meeting will help to improve IBD management. Johnson & Johnson Vietnam is always very much honored to work with you to enhance the quality of care for IBD patients in Vietnam. We wish you very good health and very happy Lunar New Year, you and your family members. All the best wishes will be come true for you. Thank you.
Xin mời quý thầy nhắc lại ít phút cho tụi em xin một tấm hình kỷ niệm.